panic attack, panic disorder, agoraphobia, a list of specific phobias, social, OCD, PTSD, GAD, hoarding, hair pulling, excoriation, and impulse control disorder. So when someone says they have anxiety, anxiety could present itself in a lot of different ways. So what is anxiety? It is an awareness of an impending danger. It's insidious, diffuse, could be vague, apprehension of the unknown threat. These unpleasant feelings, often ease or helplessness, often happen. Usually, it could be in relation to something that's imminent or something that's actual. The patient will perceive their anxiety as a threat. It is a very, very common disorder. Most patients, if I have 10 patients total, I can say roughly 8 to 9 of those patients have an anxiety disorder. An anxiety disorder is very, very common. 12 to 25% experience anxiety in their lifetime. And if there's anyone in this class who tells me they've never had an anxious moment, then I'd like you to explain to me how that is. Because even I myself have anxiety, you have anxiety. It is very, very common. It is stated that women are more anxious than men. Maybe women just present more, or they have a more outward expression of their emotion. I can't say definitively why, but women are often more anxious than men. There's also an increased prevalence in local socioeconomic demographics. And why do you think this is? Fewer support.
Yeah.
And maybe more stressors, right? Yeah, there you go, Stephanie, more stressors, right? So this is why it's more prevalent there. So it's thought that it could be genetic. I had a new intake last week too, 16-year-old girl. And as I was doing her intake, she had a diagnosis of generalized disorder. I could also tell that the mother who was a part of the intake, I could tell that she had anxiety until she later shared that, yeah, I have anxiety too. So yes, we should use this med because I also take this med for anxiety. And my mother also has anxiety. So anxiety is actually familial. It could be caused from a psychodynamic issue where there's internal struggles versus one's impulses or drives. I think it's a little bit of both, because nature, as in it could be heritable, and nurture, as in it could be learned faulty coping. Like if whenever mom was faced with a stressor or dad was faced with a stressor, you saw mom freaking out, facing became irritable, then the child can then learn to respond in the same way. It could be related to one's experience. Does that answer your question, Sarah? Welcome. It could also play into one's experiences, their relationships. It could be learning or behavioral, as it's stated here, nurture, as in one's conditioned that way. Have you ever been around someone who's anxious, who in turn makes you anxious? Yes. I have one girlfriend right now who lives all the way in Pennsylvania and is my dearest friend from childhood. But whenever I get off the phone with her or get in a phone conversation with her, I get off the phone feeling very stressed. And I'm like, why? And this is because she's so anxious about COVID, the current politics, all the restrictions. She hasn't had anyone in her house since this whole thing started in March. Her child hasn't left the home. And it's a lot for her to deal with. And then she's processing with me. We were talking like friends, not like in a session, but I get off the phone, like feeling very stressed and amped up and anxious, and I find myself trying to avoid phone conversations, and I don't want to be that person, but I have to look about my own psyche as well. So there are some medications that is said can cause stress: corticosteroids, thyroid hormones, even SSRIs. And what do we know about the class of SSRIs? Dun, 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 dun. Psychotropic drugs, yes, they can also exacerbate anxiety. But what do we know about the SSRI class of drugs as it relates to anxiety? It's a whole lot easier than that, Joel. Yes, they do block serotonin uptake. What are they used to treat, guys? Yes, they're used to treat anxiety and depression. So you're probably saying, how can a drug that is used to treat anxiety and depression cause anxiety? And they do. So this is why we tell patients that if they're taking these medications, you notice that your symptoms are worsening, they need to let their prescriber know. And very often when it worsens their symptoms, it's called like activation syndrome. When it worsens their syndrome, it's usually because there's an underlying disorder. And very often it's like a bipolar disorder when the SSRIs worsen symptoms. And you mentioned psychotropic drugs. Yes, that's listed here, as well as chemotherapy is said to cause anxious symptoms. Some hallmark symptoms of anxiety. Usually I teach in the classroom, and as I am up front talking and I'm looking at people, I can see symptoms of anxiety, the physical symptoms I can see. What are some physical symptoms you think would be present that denotes anxiety? Leg moving. The leg moving is a very common one. That one leg that's just going a mile a minute. Yes. Sweating, hand wringing, tapping, nail biting, hyperventilating. These are all signs of anxiety. So while someone is not coming out and saying, hey, I'm anxious over here, their physical appearances can tell you that you're feeling anxious. And the affective, and we say affect is the outward expression of their emotions. It can probably come out in the way they're talking, facial expressions. You mentioned pacing, so those behavioral characteristics as well. Or cognitive. How could they present anxious in their reasoning, anxiety in their reasoning? Negative talk, or second guessing themselves, talking a mile a minute, jumping from one subject to the next. So these are all different things they could be exhibiting that tells you they have an inability to focus, concentrate because they're feeling anxious. Eating changes. A lot of patients say, when I get anxious, I eat. So they could be eating too much, or they could also be eating too little. A lot of patients will also say, when I get anxious, I take a drink, calms me down. So while that's one coping skill, it's a negative coping skill, but in essence, that is what they do when they start feeling anxious, either drink alcohol or use drugs. They will have difficulty sleeping. I mean, how many times have you had an exam the next day, something big planned for the next day, and you just don't sleep the night before? I know that's me for sure. That's because you have some anxiety about what's imminent, what's about to happen the next day. So we all experience some level of anxiety. And as I mentioned, it's about our level to cope and reason through these stressors when they present that sets us apart from one diagnosis or another. Some people exercise when they're anxious. Now that is a positive coping skill. At least they're burning some energy in a positive way. They smoke. They can have somatic complaints where they're complaining that stomach aches or any other thing going on. They could have pain, GI issues. There could be lots of different issues playing into patients' anxiety. They could start feeling sick, breathing issues, urinary issues. So anxiety is not just saying I'm anxious, it could present in as well as behavioral and physical manifestations. And these are necessary to know so you can become aware of this. So while the patient is not saying to you, I am anxious, you can reason through their presentation to differentiate that from or tease that out of their behaviors. So there are different levels of anxiety. There is mild anxiety, which can be helpful and necessary in some light. It's the tensions of day-to-day life. It's not a problem to have this low-level anxiety. In nursing school, as you sit in class, as you prepare for an exam, as you prepare for your boards, you will have this low-level anxiety. And it's necessary as it sharpens your skills, it motivates you, heightened alertness and increased interest. So it aids the learning process. It's adaptive and it's necessary for survival. It's something that you need. But then if this mild anxiety progresses into moderate anxiety, this is where it starts to become a problem because now your attention is not so attentive. You have more selected attention because while you're sitting there in class, you're so anxious about this whole thing that your thoughts are racing and you're racing and you're racing and you're thinking about different things. You start feeling tense, you're unable to relax, you become restless, and you start using those defense mechanisms. By the way, did anyone happen to take a look at the defense mechanisms handout that Pam posted? Not yet, but I'm sure you will. Anxiety can also progress into a severe pathologic state. This is where one will have diminished or scattered concentration. Attention is severely limited, so you can no longer come to class and sit in class because you are not learning anything. You start having psychologic or somatic symptoms. The response is often grossly exaggerated. And even after, say you were feeling anxious about an exam coming up, even after the exam has gone and it's over with and done, you're still in this heightened anxious state. It affects your intellectual functioning, your cognitive, social, and your occupational life. So now it starts to affect every area of your life. And as it progresses, you can develop into what a lot of patients tell me they have panic attacks. Sometimes I'll have patients tell me they check themselves into emergency room secondary to having a panic attack. So they start having these panic attacks and they check themselves and you're like, it's anxiety. What are you doing in the emergency room? This is a severe level. At this heightened state, a panic attack, the patient will have difficulties understanding simple directions. They feel as if they're going to die. They can even start having suicidal ideations. They have a severe inability to differentiate between the external and the internal environment. They can even start having delusions, hallucinations, difficulties with their interpersonal relationships, and there is no concentrating going on. This is not the patient you're going to be able to reason through. How about to use your coping skills? It's way past coping skills at this point. This patient is in a state of panic. Often when patients experience a panic attack, they will spend a significant amount of time after that panic attack worrying about having another one. So just imagine you have this panic attack, you spend a lot of time worrying about getting another one. So it's almost as if you're working yourself up into getting a panic attack. They have significant behavioral changes related to the attack, so they will probably say, oh, I'm not going to take the bus anymore. I can't leave the house because the last time I left the house, I had a panic attack. Or whenever I go to the grocery store, I start feeling super anxious because once upon a time I got a panic attack while I was there. So this patient will be worried about having another one, and it consumes them. And this is how the patient will be diagnosed. If their worries continue for at least 1 month post that panic attack, it can develop into a panic disorder. Anyone ever seen anyone in experiencing a panic attack? Yep. Myself. I can tell you, I came close, pretty damn close to it a few times, but with a little bit of coping skills, I was able to work myself through. Definitely able to work myself through. I forgot what I was doing the other day, and I felt myself getting disorganized, like I was going from one task to the next, and I had to just like stop, zen, ground myself. And then I physically made a list of what it is that I had to do, listing them priority. And then I attacked each task one at a time. And I was able to finish my day, everything done. Your girlfriend has them. So they're a lot more common than you think. You're probably like, this person just needs to learn coping skills, but when they have this faulty reasoning, it becomes what it is, a panic attack. So we're going to look at some phobias. One such phobia is agoraphobia. This is a fear of places and situations that may cause panic, helplessness, or embarrassment. It often develops after one or more panic attacks. So the patient probably had a panic attack in a certain or specific area, and then they become agoraphobic about place. Like the patients tell me, I don't go grocery shopping. That's a pretty common one. Oh, I'll never go into the mall or different places where they would have had that experience that time. It often develops after one or more panic attacks, as patients overestimate the risk and their anxiety is usually out of proportion to what actually presents. Much better. Situations are avoided or endured with marked distress. It could be situations such as standing in line, being in closed spaces, open spaces, being in a crowd, public transportation, or being outside of their home alone. So there are different reasons that different places that they could have an agoraphobic reaction. And I specifically have patients who only leave their house for two things: to come to appointments or to go grocery shopping. They leave their home for no other reason. So this is the patient who you'll see spending a significant amount of time at home. So as you plan for this patient, you want to probably have supports that can go to them instead of requiring this patient to go to weekly therapy sessions or to go to weekly groups outside of their home, because the chances are they will not attend these groups. Now we're going to look at specific phobias. This is an intense, irrational, or persistent fear response to a specific object or situation. Exposure to the phobic stimulus provokes immediate anxiety. In children, they probably respond with crying, tantrums, clinging behaviors. And I must say some adults do also respond in like manners. The patient often recognizes that their fear is unreasonable. This behavior often interferes with their daily routines and social life. It often leads to avoidance behaviors. They will avoid engaging in these activities or going places. They will turn down social requests because they want to avoid, because they know or think the engagement will cause anxiety. For someone to be diagnosed with a specific phobia, must be present at least 6 months under the age of 18. So there are different treatments for phobias. There's systematic desensitization, you know what I mean. This is when the patient is exposed progressively to the anxiety-provoking stimuli, and as they're exposed, they're taught relaxation techniques. It could be ERP, which is exposure and response prevention. This is when the patient is taught to face their fears and let the obsessive thoughts occur. And as the thoughts occur, they are presented with like a neutralizing stimulus. So this is not someone walking off the street and engaging these behaviors. These are trained professionals who engages the patient in these treatments. And there's also flooding, where say I'm afraid of like reptiles, so they will flood me with a lot of reptiles, and I learn to associate my feelings of relaxation with my fear-inducing stimulus. So they will induce a stimulus, and I will learn to associate feelings of relaxation around my feelings of fear. Does anyone in this class have any specific phobias? Birds. Oh, wow. Well, snakes, I am there. Birds, no. I will, maybe because of my upbringing. Deep water. Yes, I have one of deep water too. I can swim, but I will not go in water where I cannot stand. Syringes. Jacqueline, you're going into nursing. I'm glad you got over that. Spiders, snakes, heights. Monica? I don't like heights either. I remember once I was on vacation at a hotel, and I climbed all the way to the top of this bungee jumping thing. I knew I was afraid of heights, but everybody else was doing it, so I feel pressured to do it. And I got up there and got strapped up, and as the guide was about to let me go, I'm like, no, I can't do this. And like 3-4 attempts, I'm like, nope, that's it. And he's like, it's harder to climb down than it is just to swing down. I was like, nope, I climbed all the way back down. I just couldn't do it. So we're all entitled to our own physics. Is it interfering with your life? Is it preventing you from going places and doing things? So that's when it needs to be addressed. Some specific types of phobias, it could be animal, it could be situations, it could be like a natural environment type. You have some people afraid of like the blood injection injury type, like of getting a shot, a vaccine. I remember when I worked in the Air Force, and you had those muscular looking men with the tattoos, and they looked really nice, and yes. And then when they came in for their vaccines, they're like, oh, can I sit, or I can't look. I couldn't help but chuckle, because here are those manly looking men who are afraid of a little tiny needle. But it is their right. They do have a phobia. That's what it is. So it could be some more specific ones. Acrophobia, and you should familiarize yourself with these. Acrophobia, acrobat, fear of heights. There's algophobia, fear of pain. Colorophobia, cats. Erythrophobia, fear of blushing. I can't understand how that would, I guess they're afraid of getting red in the face. Panphobia, fear of everything. Claustrophobia, which I'm sure most people know because that's very commonly used. Fear of confined spaces. Xenophobia, fear of people from different countries. And zoophobia, a fear of animals in everyday life. So like cats and dogs, like animals that we see like all the time. And birds. Yes, and birds. So we can have a social anxiety disorder. This is a social phobia. And this is why, like, when patients come to see me and they're talking about feeling anxious, I would ask, do you find that you are more anxious in like different situations? Like, are you anxious at home, or when you leave the house, or in crowds? And as they talk, I am listening for the different things that they identify as anxiety causing. So social anxiety is a marked and persistent fear of social or performance situations, usually under scrutiny of others. So public speaking, performing in public, like those kind of things. There's a fear of embarrassment, rejection, negative evaluation. It can also include eating in public or even speaking in public. Not like public speaking like on a podium, but just being out in public and engaging with others. Exposure to the situation almost always provokes anxiety. It can maybe even cause a panic attack. The patient will recognize the fear and choose to avoid situations. If you're a child, you probably just throw a tantrum. Oh, I don't want to go. I don't want to talk to him. And it's not so much I don't want to talk to another person, it's because of the anxiety that it causes them to do so. OCD, one that's also very common because everybody claims to have OCD. How often have you hear, oh, I'm so OCD, I got home and I cleaned my house, because everybody thinks they have OCD. So hopefully after today, when we learn about what OCD is, we can correct those faulty misconceptions when we hear them. So OCD, this is a series of intrusive, recurrent, persistent thoughts. So this patient will have obsessive thoughts, persistent, recurrent, intrusive thoughts. And those are the obsessions. Then they will in turn have uncontrolled repetitive behaviors because they have these obsessive thoughts, so they feel compelled to do a behavior in an effort to lessen the anxiety or the intrusive thoughts. And doing these behaviors is not something they enjoy, it's not something they want to do. It often causes them distress, but the obsession feeds into the compulsion. These obsessions can be recurrent and persistent thoughts. It could be urges, it could be images. And even though the individual tries to ignore or suppress or neutralize these thoughts or urges or images, they have a hard time doing so. The compulsions are repetitive behaviors or mental acts that the individual feels driven to perform. The behaviors or mental acts, so it could be something physical they're doing with their hands, or just saying something or counting to 100 times, like however it presents. It's aimed at preventing or reducing anxiety, but it's often not connected like in a realistic way to what it's designed to neutralize. So they could be having some intrusive thoughts about eating, and they choose to have a compulsion of counting everything they see. So it's not necessarily always connected to what the thought is. So some very common compulsions are like hand washing, checking things such as closing doors, closing windows, counting, ordering objects. It causes marked distress. So the patients know they have this problem and they're not happy about having this issue. So you won't find someone with OCD walking around, oh, I'm so OCD, and be proud of it. It causes significant impairment to their daily lives. They're time consuming and it causes them significant distress. I have a patient who has a compulsion of checking doors. And for every appointment, he's late, like halfway into his appointment, because every time he has to leave the house, he has to go back to the door 5 times. He gets to the car, back to the door to check if the door is locked. So usually I schedule him at the end of the day or before my admin period, so I have time to facilitate his visit. Does anyone know anyone with OCD, and I mean true OCD? Yes, yes. Oh, it's out there. Whatever it is they choose to count, is it that they're counting dishes all the time wherever they go? They just have this compulsion of counting dishes? Yep, so that could be a compulsion. And Chow, you know someone you see regularly who has a compulsion? I remember long before he taps his card just for it 6 times before being able to use it. See? Those are all compulsions. I remember once before I even became a nurse, I was in a pharmacy, and this older gentleman was in front of me. And after he bought one item, and I never forgot him to this day, and he asked the cashier to put it in the bag, turn it 360, then put it in another bag, turn it anti-clockwise, put it on the counter, face it to the right before he could pick it up. And I'm like, what is going on here? And it was years later when I could reason through it, I could understand what he was doing. Oh my goodness. You have to test if something is hot. That could be potentially dangerous. And these patients, they recognize that these things are excessive or they're unreasonable, but they have a very hard time controlling these compulsions. My goodness. It's also said that up to 30% of patients with an obsessive compulsive disorder, they also have tics. We spoke about tics last class. So what do we treat an OCD with? SSRIs. And this is why SSRIs are so loved, because they treat a wide array of things. Or anxiolytics. Post-traumatic stress disorder. So pretty much something happened and it affects this person in a detrimental way, and it usually lasts a very long time. So symptoms develop after a personal experience involving actual or threatened death or serious injury. It could be to oneself, and it could also be to others. Also, it could happen for first responders who have repeated exposure to traumatic events. My spouse is a first responder, and I can tell you the traumatic stories that I hear at the end of his shift every time. I was like, wow, like, do you need therapy? You want to talk about some of the stuff you see or what happened last night? It can be very traumatic. And if the person has any underlying issues or poor coping skills or not enough supports to discuss or work through these symptoms, they can themselves develop a stress disorder from work-related issues. This person will have intense fear, hopelessness, or horrors. And it's even more intense if the trauma is man-made, such as gunshots or stabbing or rape or something like that. They will have persistent flashbacks. A very common one my patients with PTSD will share is that they have intrusive dreams. They will try to avoid stimuli associated with the event. So did something happen when they went to a party or went to a park? So they will try to avoid those things that they can associate it with the trauma. They are more than likely in a state of hyperarousal most of the times, hypervigilant, and increased startle reflex. They have persistent negative or guilty feelings. They can have difficulties enjoying life as well as loved ones, because very often they're maybe even angry, irritable because of their trauma. What is one group that has a large population of people who suffer from PTSD? Yes, veterans. To be diagnosed with PTSD, your symptoms must present for more than 1 month, often causes distress or impairment in functioning, causes marital familial distress. This is not someone who is saying, I have PTSD and everything appears to be normal. They will have significant distress from these symptoms. So remember I said they have to have these symptoms for more than a month for it to be labeled as PTSD. So something happens to you and you feel stressed from the incident. It will not immediately be called PTSD, but more appropriately labeled an acute stress disorder. This is like PTSD and exposure to a traumatic event, serious injury or threat. The response could be fear, helplessness, or even horror. You re-experience this trauma through images, dreams, flashbacks. So it sounds a lot like PTSD. You will try to avoid the stimuli. You can have increased arousal, difficulty sleeping, poor concentration, irritability. And I harp on irritability and anger because usually people think of PTSD, they think of anxiety. So key for you to know, irritability, anger are definitely symptoms that present with PTSD. It also causes you significant distress. It could cause some derealization, depersonalization, negative mood. It could last up to 2 days. or a maximum of 4 weeks, because once it goes beyond the 1 month mark, what does it become? Yes, you guys get it. PTSD. A generalized anxiety disorder. So this is free-floating anxiety. You're anxious when you wake up in the morning, you're anxious when you go to bed, you're anxious when you're happy, you're anxious when you're sad. This is someone who is just anxious. This is excessive anxiety and worry lasting at least 6 months. It is recognized by the patient as excessive. They can have restlessness, edginess, fatigue, poor concentration, irritability, muscle tension, sleep disturbance. So it affects them in a wide variety of ways. And did I add, it is very, very common for patients to have a generalized anxiety disorder. It causes them, if the patient doesn't recognize it, so it would be hard unless they think that's their baseline functioning, where they're just used to being on edge and restless and edgy and poor concentration. But more than likely, it would have been recognized by those around them. Or if they don't recognize it, you can point out to them, hey, I realize you have a hard time sitting still. You're a little bit edgy and irritable. I realize you have a hard time focusing and concentrating. It seems that you would appear as anxious. Do you think you're anxious? So sometimes you have to help them to reason through the symptoms also to determine what is going on. Because if you ask them, are you anxious? It's likely they can say no, because I've had it happen. Patients walk in, any anxiety, any depression? No. How would you describe your mood? Well, you see, my focus and concentration is totally off. I've been feeling really tense. I'm not sleeping. So as they start working through the symptoms with you, you come to realize that, haha, it is in fact anxiety or depression. Sometimes it's education. So it's not a different condition if they don't recognize it. How different, Sarah? I'm not sure what you're asking.
I guess I'm wondering, it's on here, is it like, does it have to be recognized in order for it, like, is that a diagnostic criteria?
I mean, recognized by the patient or by someone else?
By the patient.
No, it doesn't have to be recognized by the patient to be diagnosed.
Okay. All right. Thank you.
Yeah. Then we have hoarding disorder. I have one patient who's a hoarder. It causes persistent difficulties in discarding or parting with possessions regardless of their actual value. This difficulties is due to the perceived need to save the items and avoid the distress associated with discarding them. Hoarding results in an accumulation of possessions that clutter living spaces and compromises the use of these spaces. It causes significant distress, impairment in social, occupational, and other functions. She is devastated that she's a hoarder. She laments not being able to have family over or have a clean house, but she didn't choose to hoard. It is a disorder, and she's having a hard time working through it. She's in therapy. She's taking, so there's no anti-hoarding pill, but there's something that can treat the anxiety that she would experience when parting with things. So we're treating for anxiety and through therapy. And I must say we haven't made much progress, but she's reasoning through it effectively. Then we have trichotillomania. This is the hair pulling disorder. This is the patient, and I just don't mean hair pulling, like pulling on your hair, I mean pulling on and out. You're gonna pull, you're pulling their hair out of the hair shafts. This is the pulling out of one's hair with notice of a hair loss. I have quite a few patients. It's more common than we think. I have one patient who has absolutely no hair on the back of his head because he feels anxious. He's just pulling back hair. I have one adolescent who pulled out one entire side of her head. I had one girl who pulled out both parts of the front. So it's a very, very common disorder. They will have some tension, and pulling the hair relieves the tension. It provides pleasure and gratification or relief when pulling out the hair. It can cause significant distress or impairment. And I should also point out it's not just hair from the head. It could be eyelashes, body hair, pubic hair, wherever there's hair, they could choose both. Then we have an excoriation disorder. This is a patient who repeatedly picks their skin, resulting in skin lesions. Most use their fingernails. Some may use tweezers, pins, or other objects. I have one patient with this disorder. She picks her face, the T-zones, hair and her chin. Every time she comes to see me, she has these bright red open spots on her face. And the mother would tell me it was better before she came. I swear she does it before every appointment. So maybe it's the anxiety of leaving the home to come to the appointment why she does this, because she doesn't leave the home for any other reason. The patient has repeated attempts to decrease or to stop. However, it causes significant impact and distress in their social, occupational, and other areas of functioning. They often feel shame or disgust. She comes in, oh, Zoe, don't look at my face. I know it looks horrible. And you're like, then why did you pick it? That's because she can't stop herself from picking. Usually not related to any substance use, and it may continue for months or years. Another story I'd like to share with you, I was doing a patient's intake, and it was summertime. It wasn't summer, it was like early spring, and she had on, her legs were exposed. And as I'm doing my intake, I'm doing my head to toe, I'm assessing her while we're talking. And I looked at her legs and I saw several areas of excoriated skin. So you know where I'm going, I'm like, excoriation disorder. So, of course, you address it with the patient like, hey, I've noticed that you have several areas of your skin, of your legs that are missing skin. Can you tell me what happened there? Even though I already think I know what happened there. And she goes, oh, that was from my crack pipe. I'm like, how? How did that happen? She goes, oh, in the winter months when I smoke the crack and I had my boots on, I would stick the pipe into my boots after using it each time, and that's where it burned my legs. So I was left educated that day. I learned that crack pipes get very hot, and it looks very similar to an excoriation disorder. Yes. So this is where you say substance, it definitely impairs judgment and insight, because it wasn't one burn or two burns, it was several open areas on her legs. Then we have an impulse control disorder. This is a patient who has trouble controlling emotions and behaviors, often violates the rights of others, or their behaviors often conflicts with societal norms. It could be pathological gambling, pyromania, which is starting fires, kleptomania, which is stealing, or an intermittent explosive disorder. My patient I saw just before I logged on for class, he has an intermittent explosive disorder. I've never seen it, but he appears as the meekest and mildest person ever, but he has this disorder. As I continue to interact with him, I find the need to say in remission or something, because when was the last time he reacted in this way? How do we treat these different anxiety disorders or trauma and stress-related disorders? Medication is one route. We can choose to use anxiolytics or SSRIs. Cognitive behavioral therapy, also recommended, where they can look at their thoughts, their feelings, restructure their behaviors. Relaxation techniques. You're amped up, you need to learn how to relax, kind of goes hand in hand. Behavioral techniques, the systematic desensitization, exposure, or the flooding that we mentioned before. Pharmacology. Benzodiazepines. So benzos are a class of drugs that are prescribed for, these are the anxiolytics. Does anyone know anything about benzos? The Xanax, the Ativan, the Klonopin, the Valium? They're addictive. I'll praise the Lamb, yes. And if you don't know anything about these drugs, you need to educate yourself, because trust me, your patients, they know all about these drugs. They can tell the onset, duration, they know these drugs. This is because this is a drug that's addictive, high abuse potential. There's a lot of patients that seek to get these drugs, or they will sell these drugs. They have a high street value. I can tell you that most of my discord in my practice has been surrounded by benzodiazepines, either my resistance to initiate a therapy or to continue a therapy. It usually doesn't end well. Patients do not want to hear about me messing at all with their benzos. They have a lot of benefits. They're fast acting and they're very useful if a patient is having a panic attack. So PRN prescription, yes. And this is why I try to educate my patients that it is not appropriate long-term treatment. I will not treat your generalized anxiety disorder with a benzodiazepine. Because it's not treating the problem, it's like putting a Band-Aid on it every time. How about we use an SSRI, which seeks to work on the neurotransmitters in your body, where we can address these anxious symptoms at the root and not as they present. You have some patients with enough insight and judgment to reason through effectively and say, yes, I understand. I had one patient yesterday, she was asking me for Xanax. She goes, I know it's addictive. I'm from a family of addicts. I know the abuse potential. Don't give me much. I just want like 10 tabs for the month. I will only use it sparingly. Give me the lowest dose. So you need to educate yourselves as well as the patients because they know this stuff. Disadvantages, addiction can lead to tolerance, withdrawal. It can cause cognitive dulling. And this is what I try to explain to my patients, especially my older patients who start telling me, oh, my focus is off, my concentration is off. How about we took a look at your benzo use? It is even more difficult for those patients who I inherited, who are already on this therapy for years and years and years. Like you try to make a change and they're not having it. And I try to educate them about the cognitive implications for benzo use. And sometimes I've had a few patients who will say, you know what, Zoe, let me try going without it and see how I do. It can cause drowsiness and sedation, and this is why you have to educate your patient. If you're taking this drug, lay off the alcohol, stay away from drugs because it's an added sedative effect, and it can have dire consequences. The elderly, it's going to impair their gait, their cognition, everything. So you want to educate them about their risk for falls, drinking water, enough water to stay hydrated, teach them about how it affects their livers, their kidneys. Very often patients will tell me, I only want benzos because benzos are the only things that work for me. I know it does because when I don't have my benzos, I feel crazy, like I'm vomiting, I sweat, I have nausea, I have difficulties falling asleep, my stomach, it hurts so bad. And they think they're having really bad anxiety, but what in fact are they having? Withdrawal, exactly. And this is why you have to educate them. This is a drug that has addictive properties. This is a drug your body will be addicted to, so you don't have it. It's craving for it. It wants it. So this is why if I'm taking a patient off this drug, I can't say, nope, I'm not prescribing it. You won't get it anymore. Nope, I go down like 0.25 of a milligram every month. And even then, they're not happy because that is just too much and too fast. Some other anxiolytics are Buspar. You will see Buspar prescribed, not PRN, but patients take Buspar regularly. It is FDA approved for anxiety. It's very effective. Other ones you'll see are Vistaril, which is the hydroxyzine. This is from like the Benadryl family. I prescribe that a lot, or you'll often see for sleep, even though it can be used for hives and anxiety. So this is widely used. So outside of a benzo, this is the only other drug that's used PRN for anxiety. You'll also see Paxil. So there are lots of other drugs that treat anxiety. The more popular ones you'll see are the gabapentin is very, very popular. And a lot of these drugs are drugs that are used off-label for anxiety. Because gabapentin, what do we know that gabapentin is usually prescribed for other than anxiety? Nerve pain, right. So this is why, especially like when I get a new patient and they are on gabapentin, I'm like, can you tell me why you're taking gabapentin? And this is why when you go over patients' med lists and they have gabapentin, can you tell me why you're taking gabapentin? Because you may be assuming it's for nerve pain, but it could be for anxiety as well. So if you go down the list, clonidine, guanfacine, these drugs can also be used for ADHD or for controlling blood pressure. There are lots of different indications for these drugs. So you want to make sure you have a clear understanding of why patients are taking these drugs. Then we have the SSRIs, which are the antidepressant groups. And like I said, they're effective for many disorders: anxiety, depression, tics, PTSD. They treat a wide array of things, and this is why they are so helpful. That's the Prozac, the Paxil, the Lexapro, Selecta, Zoloft, and there's your list. So a patient is taking these drugs, you're looking at their med list, and you recognize it as being an SSRI. You want to clarify with the patient, can you tell me why you're taking Prozac? Because while it's FDA approved for a depressive disorder, they could be using it for anxiety, for tics, for something else. You want to make sure you have an understanding of why they're taking what they're taking. Disadvantages of SSRIs: they can cause weight gain, decreased libido, which is very, very common. I've had quite a few patients come back to me and be like, you know what, I don't feel depressed anymore, but I've noticed that I'm not interested in sex. And I've only had a few patients who say change the drug. I've had patients who are like, no, my depression is fine. I don't want to mess with it. The med is working, and I will educate them. I'm like, no, let's work to change the drug, because then you're having issues in your intimacy. That in itself is going to create further problems in your social life, your interpersonal interactions and stuff. So we usually work to do what will make everybody happy. That is the end of section 2. So we're going to take another 10-minute break. Was upstairs better than downstairs?